My name is William Moss, and I'm the Executive Director of the International Vaccine Access Center here at the Johns Hopkins Bloomberg School of Public Health. And it's my great pleasure to introduce this webinar titled The Future of Pneumonia Prevention, Building on the Success of Vaccines. Here at the International Vaccine Access Center, our mission is to accelerate global access to life-saving vaccines through the development and implementation of evidence-based policies. We've been celebrating World Pneumonia Day with events like this over the past decade, and really based on much of our work, including our annual Pneumonia and Diarrhea Progress Report that tracks progress toward reducing the burden of pneumonia and diarrhea in 15 high-burden countries, through things like ViewHub, our web-based platform where we track vaccine introductions, and through long-standing work with the Perch Project on studying the etiology of pneumonia. This year, we celebrate successes in rolling out pneumococcal conjugate vaccine, but we also recognize the challenges, particularly challenges posed by the COVID-19 pandemic. And the pandemic has also given us some hope and optimism that messenger RNA vaccines or adenovirus vector vaccines may provide additional tools in our fight against pneumonia. I'm going to introduce our four speakers and panelists for today. First, Dr. Arup Deb Roy, who's a public health specialist with more than 15 years experience working on immunizations with NGOs and UN agencies. He's currently the country lead for new vaccine introduction projects with JSI in India, and particularly focusing on pneumococcal conjugate vaccine introduction in India and scale up in India. Dr. Lee Hampton will be the second speaker. He's the Vaccine Preventable Disease and Vaccine Safety Focal Point for the Secretariat at Gavi, the Vaccine Alliance. Dr. Hampton is a pediatrician and medical epidemiologist who oversees Gavi's investments in disease surveillance and vaccine safety. He's worked on pneumococcal vaccination policy, among many other pneumonia-related projects. Our third speaker is Dr. Wangechi Kungushia, who is a research fellow in the Epidemiology and Demography Department at KEMRI Wellcome Trust Research Program in Kilifi, Kenya, where she assists in the oversight of the pneumococcal conjugate vaccine impact study. Wangechi received her master's and PhD degrees here at the Johns Hopkins Bloomberg School of Public Health in the Department of International Health, and worked for a number of years with us at the International Vaccine Access Center, and we're delighted to have her rejoin us for this seminar. Our fourth speaker will be Professor Keith Klugman, who's director of the Pneumonia, Meningitis, Neonatal Sepsis, and Antimicrobial Resistance Programs at the Bill and Melinda Gates Foundation in Seattle, Washington. Professor Klugman is the Emeritus William H. Fogey Chair of Global Health at the Hubert Department of Global Health at Emory University. And Dr. Klugman has made enormous contributions to the preventing the burden of malaria across the globe. So I'm going to turn first to our first speaker, Dr. Roy. And Dr. Roy, I'll hand it over to you.
Thank you, Dr. Moss. Greetings from India. So these are pretty exciting times for all of us who work in the immunization space in India, even in the midst of the COVID pandemic and the massive COVID vaccination drive that's happening in the country. India has successfully scaled up PCV in its routine immunization program. So over the next couple of minutes, I'll just take you through the broad highlights of this expansion of PCV, especially focusing on the rapid expansion that has happened this year in the midst of this COVID pandemic. Andrew, next slide, please. So the agenda was set at the highest level. So in this year's union budget speech by our India's union finance minister, she specifically mentioned about scaling up of PCV across the country and through domestic funding. So that actually set the agenda for this rapid scale up that happened this year in the country. Next slide, please. Okay, now if you go back a few years, how this whole story went along. So, India has a very robust evidence-based decision-making process for introduction of a new vaccine. And we have our NITAG, GANTAGI, which recommends, first give a recommendation for a new vaccine introduction in the routine immunization program. And this happened for PCV in August 2015, and followed by this DAMPARD program committee, which approved the entire recommendation. And finally, the interministerial mission steering group gave the approval for PCV introduction in the routine immunization program. And in 2017, the PCV was introduced in a phase-wise manner across the country, starting off with 6 high-burden states. So what has happened for PCV introduction compared to many other earlier introduction of maybe an example of pentavalent vaccine, which was introduced in a high-performing state. For PCV, the introduction was in a high-burden state. So if you look at those initial states where the PCV was introduced, the states of Uttar Pradesh, Bihar, Madhya Pradesh, Rajasthan, these are in the central part of the country, which is a very high burden of childhood pneumonia. So from the equity lens, this is how the government thought about it. Let's introduce in a phased manner, starting off with the high burden states. The another important milestone in this journey was because initial introduction happened with the offshore vaccine from offshore manufacturer. So in India, the first indigenous PCV vaccine was licensed for use in later half of 2020. And with the availability of a vaccine manufactured by a local manufacturer and committed domestic funding from the government, so this actually triggered the whole series of events that led to a pan-India rollout of PCV. So it started again in the Q2, 14 additional states were included for this. And again, the equity lens was applied. So these 14 additional states were those states in the remotest northeastern part of the country, and even few other high burden states like Jharkhand, Chhattisgarh, and Orissa. And finally, over the next couple of months, the pan-India rollout happened. And on 29th of October, just a few days back, India completed its nationwide rollout of PCV. And as you can see in the picture on your extreme right, the Union Health Minister, Present Health Minister, actually there's a small event in the ministry where they launched the awareness materials around PCV. Next slide, please. So as you said, it was a multi-year rollout of PCV in the country. So if you see the initial years from 2017 to 2020, it happened in not across all entire states. So it concerned a few districts, a particular state, and next year it was scaled up. And one of the learnings from those initial years was that, in India, there's a lot of inter-district migration that happens. So once you don't cover in one state in one go, it becomes difficult because the child, there's a huge chance of dropouts happening. But yes, the constraint was, the operation challenge was that we didn't have an indigenous vaccine from a local manufacturer, so vaccine supply issues were there. So once we had a local manufacturer manufacturing PCV vaccine, so for the final phase of expansion in 2021, it was decided that it will happen across a particular state. It won't happen in particular districts. So the remaining states, they launched in one go, and in over a period of 6 months, the remaining states of the country introduced PCV. Next slide, please. So there's a snapshot, again, going back to how things moved from 2017 to 2021. So if you can see in the initial 4 years of the introduction, although 6 states were covered, but that has the major part of the India's cohort. So almost 50% of the annual cohort was covered in the initial 4 years. And this year, the remaining 50%. But what was unique for this rapid expansion this year that happened is that this was expanded in those areas which is very diverse geographies, topographics, very unique challenges, starting from the Himalayas in the up north to the remote areas of northeast, to the coastal areas, to the islands of Andaman, Lakshadweep. So, and this all happened in the midst of the pandemic and in the midst of this massive COVID vaccination drive that India is having right now. So over the next couple of slides, I'll be focusing more on what has happened during this last 6 months, especially this, what are the innovations that the program had and to overcome the challenges that we encountered along the way. Next slide, please. Okay. So when a new vaccine is introduced, so the four major activities that happens around it is, one is the preparedness assessment, the capacity building of the system, the health workers, the program managers, the supply chain, vaccine procurement, and finally the communication and the conversations around and the launch of a new vaccine and media advocacy and all. So in the preparedness assessment, the classical way is what we always used to do in India prior to a new vaccine introduction was the checklist. We had sent a checklist which is to go out to the particular states for districts and state checklist. But when we started off this exercise in the early part of this year, we realized that India, as you know, started the COVID vaccination in January this year. So the system was stressed, and it's the same UIP system which was being used to for the COVID vaccination campaign. So it was the managers, the data managers, the frontline workers simply didn't have the time and the bandwidth for that sort of elaborate exercise. So what happened is that we digitized this entire checklist. So we scripted that checklist into a digital tool. And I'll be talking in more details in one more slide on that digital tool. Now, on the capacity building, again, the in-person trainings were not possible because of the restrictions, travel restrictions, and again, and other COVID appropriate behavior that has to be followed. So we shifted to an online platform. But along the way, we realized that there were issues around net connectivity, and also we followed a hybrid model. Some places had a classical online training, some had a mix of both. And even I'll be talking a bit more on that. Now, along the way, as I told you, the initial stage which launched PCV from 2017 to 2020, the vaccine was from offshore manufacturer. So as the local manufacturers, the local pneumococcal was licensed for use. So in this period, as the new states were launching the vaccine, so the older states also switched over. So they switched from the earlier product to new product, so the pneumococcal. So that also happened during the past 6 months. So that is also an additional challenge for the system. And on the communication front and on the media advocacy, again, since in-person media workshops and other things were not possible, most of them shifted to online platform. And even for those launch, where usually the vaccine launches happens in the presence of the ministers and all. So they join an online platform with the primary health center where the kids were vaccinated. So we encountered these challenges, but we found a way around it. And I'm talking in more details in subsequent 2 and 3 slides on this. Next slide, please. So coming back to that digital tool that was developed for the preparedness assessment. So as I said, the checklist was scripted in a digital tool, but what was two important piece of it was that we had a completion dashboard and analytics dashboard. Both were real time. So why this was important? Because really our initial days when the PCV expansion was being discussed, we were very clearly told that the priority, and obviously the priority was always COVID management and COVID vaccination. So whatever bandwidth is available after doing all those activities would be utilized for PCV expansion. So we were mindful of that fact right through the entire course of the PCV journey. So this digital tool was really helpful for us because we knew exactly when did this district program manager interact with this tool, what was the percentage completion, where they're stuck and all. So we could very targetedly approach those people. Okay, you were stuck there, so we can help you out with those assessments. The other thing was that there was an analytics dashboard also in that tool. So the state level program managers could see where the gaps are and on a real time basis as they kept on filling up this checklist, and they could plug. And I'll give an example of, say, we identified that maybe the overall state has enough cold chain space, but a particular district may have less space. Then we realized that some equipments were lying somewhere which are not used. So that rational distribution of cold chain equipments happened. Next slide, please. So the traditional training materials, we already had the operational guidelines and frequently asked questions. And because of this COVID challenges, what we did, and this first time again in the program, so the frequently asked questions which are developed for the frontline health workers were converted into a series of 4 animated videos. These are not very high-end animations because we kept it purposely very light so that it could be extensively disseminated even in areas of poor net connectivity. So the frontline workers could download these videos in their smartphones, and these had all the key messages that were required for a new vaccine introduction, for PCV introduction. So that was another innovation that was that the program did during this COVID times for training as a training tool for the frontline workers. Next slide, please. Now, focusing on the training aspect of it, as I said, that we shifted to an online platform and hybrid platform. But one of the important takeaways from this was that the beneficial effect of the benefit of online training was that the flexibility of timings. So since they were not required to come in person for the training, so what happened is that they could schedule the training in the evening hours, so in late afternoon and all. So that ensured that neither the COVID vaccination activity was hampered, and even at the same time, the PCV training sessions could also happen. And yes, the availability of, because in India we have the extensive WhatsApp groups, so which is that this was really helpful to her for extensive dissemination of those links for that for those online trainings. Next slide, please. Broadly summarizing, again, as I said, it's a very short presentation and so many things happen, but just summarizing the broad key highlights around PCV introduction. The phase 1 introduction was planned looking at the burden of the disease, and it was done accordingly. One of the two important factors for this rapid scale up in this year was the domestic funding and the availability of a vaccine produced by a local manufacturer. And the other thing is that we had a dedicated team at JSI for this PCV introduction. And why this was important is that, you know, that all immunization partners, everybody was so occupied with the COVID vaccination. So it was a small team which actually drove it and interacted closely with other partners and government counterparts to ensure those timelines were met and the activities could go on. The other thing was that, as I said, it was a budgetary announcement. And again, anything that's announced in the union budget is meticulously followed up. So every fortnight, they take an update from respective ministries. Where are we on those announcements? So this highest level of monitoring, constant monitoring was really helpful too, because we had competing priorities. But even in the midst of all of this, the PCV introduction was almost on track. And in fact, we finished ahead of schedule. Yes, the COVID vaccination campaign stressed the system, but one of the beneficial effects of that was that there's so many conversations happening in all medias around vaccines and vaccination. So there was a positive thing that PCV benefited from them. And the good part is that we had very positive media coverage around PCV rollout across the country. And yes, it goes without saying, and the seamless partnership amongst all partners led by the immunization division was really, really helpful. So that's all about our slides. I just leave you with two pictures. It's just two pictures of the last mile, as you say, from the next slide, from the Himalayas, the Ladakh to the dense forest areas of Jharkhand. So the PCV is, we are reaching out to the remotest area with the PCV vaccine. And next slide, please, Andrew. So from as I said, from Ladakh, from the mountainous region of Ladakh to the dense forest interior areas of Jharkhand. And I think the most important part is that, Andrew, next slide, please. I think the smile in the mother's face, I think is worthwhile. All this effort, all this hard work. I think when you see that smile in the mother's face, I think that makes it worth it. Thank you. That's all I had. Thank you so much.
Thank you so much, Dr. Roy. That was remarkable. And again, to see the continued progress, the dramatic increase of those bars of I don't know, month during each year, and especially given the context of the pandemic, it's really, really, really remarkable. And you know, we have talked about IVAC organized this to sort of take stock of World Pneumonia Day kicking off tomorrow and where we are, and India has just been a remarkable experience for PCV during that time. So we're going to switch gears a little bit to talk about sort of a global snapshot and where PCV, Gavi's efforts to advance PCV globally, given sort of now that we've highlighted or sort of previewed with one country's superstar experience. So over to Dr. Hampton for your comments.
Thank you. Next slide, please. So the inspiring story that Dr. Roy just described about India's introduction is, as you know, just part of a larger story about the rollout of pneumococcal conjugate vaccine across the world. And at Gavi, the Vaccine Alliance, we're very proud of the fact that 60 of the countries that have introduced pneumococcal conjugate vaccine have done so with Gavi support. And unfortunately, that's the vast majority of countries that are eligible for Gavi support. So it's been it's an accomplishment we're very proud of. Next slide, please. So Gavi provides support to countries to introduce PCV in a variety of ways. So there's basically two main options for countries. One is for vaccinating children through routine immunization, and that's very much the baseline, the foundation of any work. And then in some countries, they may choose to introduce PCV simultaneously across the country, or as was described by Dr. Roy, it may be phased in over time in different geographic areas. The other main option is that countries can also conduct catch-up campaigns to try to vaccinate children who are up to 5 years of age who just weren't able to receive the vaccine when they went through the infant routinization program because the vaccine wasn't available at the time. And in support of both this routinization foundation and then the catch-up campaigns, Gavi will provide vaccine introduction grants as well as operational costs for the any catch-up campaigns. And obviously, our goal is that countries should try to get the vaccine to as many children as quickly as possible, because that's how it has most effect, but fully realizing that there are important logistical considerations about when countries can introduce the vaccine and how quickly, and without the need to use a phased approach or catch up. And we very much work with countries to try to make sure that our support fits their needs and what they can do. Next slide, please. In addition to supporting the introduction of vaccine and catch-up campaigns, Gavi has also supported pneumococcal disease surveillance and impact studies, largely to encourage the use of pneumococcal conjugate vaccine, demonstrate the need for the vaccine through burden studies, but also the value through impact studies to hopefully encourage countries to maintain funding for PCV procurement and use over time. So one of the examples of our support in that area was funding for the Global Invasive Bacterial Disease Laboratory Network that was organized by WHO. And if you look at the countries that participated in this laboratory network, there's a lot of overlap between those countries and the countries eligible for Gavi support, and it's not a coincidence. We definitely saw the value of the data. Next slide, please. Recently was able to collaborate with some partners at WHO and CDC to try to evaluate the impact of the work in terms of supporting pneumococcal disease surveillance and the association between that work and PCV introduction. So we looked at which countries had participated in the WHO Global Invasive Bacterial Vaccine Preventable Disease Surveillance Network, which again was largely geared towards helping countries and share data and experiences around pneumococcal surveillance, as well as other pneumococcal surveillance networks. We also looked at World Bank economic classification, eligibility for Gavi funding support, and introduction of pneumococcal conjugate vaccine between 2006 and 2018. And of the 194 WHO member states, we found that by 2018, 145 had introduced PCV. 150 of them, not necessarily the same countries, had reported conducting pneumococcal disease surveillance. And then 54 countries in particular had participated in the Global Invasive Bacterial VPD surveillance network between 2008 and 2018, largely in low and middle income countries. And then 44 countries just hadn't done any pneumococcal disease surveillance. Next slide, please. So in looking at those different factors and combining them through a multivariate logistic regression analysis, we found that countries that participated in pneumococcal surveillance networks were more likely to introduce pneumococcal conjugate vaccine, specifically countries that were in the GISN or any pneumococcal surveillance network had 2.6 times higher odds of introducing PCV than countries that had not conducted such surveillance or participated in such networks. We also found that the GISN in particular seemed to be very effective because countries that were in the GISN were 4.3 times more likely in terms of their odds of introducing PCV than countries that had conducted invasive pneumococcal disease surveillance but had not participated in the GISN. And then we also found that not surprisingly, that Gavi eligible countries also had benefited from that support. So the Gavi eligible countries were as likely to introduce pneumococcal conjugate vaccine as high income countries in comparison the countries that were just above the Gavi eligibility thresholds, the middle income countries that were not eligible for Gavi support, were noticeably less likely than high income countries to introduce PCV. So the access to Gavi countries helped to bring up those Gavi eligible countries to the same level as high income countries. We did a parallel analysis looking at rotavirus and found similar findings where countries that participated in rotavirus surveillance networks and conducted rotavirus surveillance were more likely to introduce rotavirus vaccine. But at the same time, the one data point we had on how much rotavirus countries had, which was their degree of positivity and whether or not they had a higher proportion of their diarrheal samples positive for rotavirus than the global median, the countries that had more rotavirus, basically that measure, were not more likely to introduce the vaccine. So this suggested that while the data may have played a role in encouraging countries to introduce the vaccines, that just participation in the surveillance networks and the discussions and the awareness to decision makers that the sharing information through these surveillance networks brought was probably at least as important as whatever data they were generating. So if nothing else, our study found that the advocacy efforts and the networking and the information sharing that's been done over the last 10 years probably did make a real difference in terms of introducing encouraging countries to introduce the vaccines, maybe even more so than the actual scientific data that they generate. Next slide, please. With that in mind, Gavi continues to see pneumococcal surveillance and impact data as important for guiding decision-making in different ways. We continue to fund pneumococcal surveillance and impact studies in Burkina Faso, Kenya, Mongolia, and Nepal. And at least from our perspective, from a vaccine program perspective, our key research questions at this point involve things such as the effectiveness and duration of protection from a 2+1 schedule in all regions. So it may make sense to shift from a 3+0 schedule to 2+1 in many contexts. Also, what serotypes are circulating in the regions with Gavi-supported vaccines, such as Africa, and we're potentially looking at serotype replacement, which is we've seen in other regions, such as North America, between PCV7 and PCV13, for example. If so, we'll need to change up the vaccines. The effectiveness of a reduced dose schedule, that would be more financially sustainable. So, for example, if we could go by a 2-dose schedule, that'd be fantastic if there weren't major epidemiological trade-offs involved. And then finally, what are the best approaches to accelerate increases in pneumococcal vaccination coverage in reach unvaccinated children? Next slide, please. So the good news, and this builds on one of the comments in the chat, is that over 255 million children had been immunized with pneumococcal conjugate vaccine with Gavi support. So that's great. That's definitely a lot more than would have happened otherwise, but there's a lot more to be done. So the good news is that coverage with pneumococcal conjugate vaccine has been steadily increasing in the countries that are eligible for Gavi support over time. And so last year we reached 51%. So that's a lot better than 0, which is where we were about 12 years ago. But there's a lot to go. We have 49% of children in just these Gavi eligible countries who are not receiving the vaccine. And we obviously would like to increase that. So reaching these unreached children and making sure that all under-immunized children in Gavi eligible countries receive pneumococcal conjugate vaccine and other life-saving vaccines is the priority for Gavi at this point. And we look forward to continuing to work with all the partners on this call to try to address the needs of those children, make sure they get vaccinated. So next slide. Thank you, and very happy to hand off to the next speaker.
Thank you very, very, very much. It's really remarkable. Again, the sort of highlighting the contribution of data, especially surveillance, et cetera. And really Gavi's commitment is impressive. One of the countries that was highlighted and was discussed was Kenya. And so I'm going to turn it over to Dr. Kagusha to discuss her work in Kenya at the country level to kind of advance PCV within the context of all the other competing priorities. Over to you.
Thanks, Victoria. So as you've mentioned, I'm going to share updated findings on the impact of PCV in Kenya and my thoughts on future priorities for the PCV program. Next slide, please. 10-valent pneumococcal conjugate vaccine was introduced into the infant immunization program in Kenya in 2011, using a schedule with 3 primary doses and no booster. The primary doses are administered at ages 6 weeks, 10 weeks, and 14 weeks. Our surveillance and impact evaluation is conducted in Kilifi County, which is shown here in the map. And in Kilifi, PCV was introduced along with up to 2 catch-up vaccination doses among children below 5 years of age. The surveillance and evaluation of PCV impact has been conducted since 2009 under the pneumococcal conjugate vaccine impact study. Next slide, please. The PCVS study, as we call it in short, has been conducted in collaboration with the National Vaccines and Immunization Program, the Kilifi County Department of Health, the London School of Hygiene and Tropical Medicine, and with funding from Gavi, as has been mentioned by Lee. Next slide, please. So I wanted to acknowledge that PCVS has been supported over the years by a team that's led by Anthony Scott, and certainly not all of the past and present PCVS team members are included in this slide, but this is just to acknowledge that the methods and findings I share are the cumulative work of many people over many years. Next slide, please. So to provide some context for people who are not familiar with our integrated surveillance system, I'll just talk about the components. The Cambry Wellcome Trust Research Program has an integrated surveillance system that has 3 components: community, clinical, and laboratory surveillance. The population surveillance is conducted within the Kilifi Health and Demographic Surveillance System. And the location of the KHDSS is shown in the gray shaded area on the map. It currently has a population of about 300,000 people. And the residents are typically enumerated 3 times a year, and data on births, in-migrations, and out-migrations is collected. And since 2009, we have conducted annual nasopharyngeal carriage surveys among randomly chosen residents of the Kilifi Health and Demographic Surveillance System. And this year, we also conducted a vaccination coverage survey that I'll talk about later. The second component is clinical surveillance at the Kilifi County Hospital. And in that surveillance, key clinical data are recorded electronically and then linked to the demographic surveillance data for individuals who are resident within the demographic and surveillance system. And this is used for estimation of population-based event rates, including estimation of clinical pneumonia incidence rates. Children with clinical pneumonia are also invited to have a chest X-ray taken to contribute towards surveillance for radiologically confirmed pneumonia. Virtually all children who are admitted to the pediatric ward have a blood sample collected for blood culture, and adults with suspected invasive bacterial disease also have a blood sample collected as part of our invasive pneumococcal disease surveillance. And the third component is laboratory surveillance, and this is done at our labs here. And this includes microbiological testing, including testing for pneumococcus. And this is all linked to the clinical data and also to the demographic surveillance data. Next slide, please. So I'll now share some results from the integrated surveillance, but I just would like to caveat that these results are preliminary and subject to change before they're finalized. So we know that vaccination is one of the key interventions for preventing pneumonia, and we leverage the community surveillance component to conduct a vaccination coverage survey between April and June of this year. And this included a random sample of children below the age of 5 years who are resident within the Kilifi Health and Demographic Surveillance System. This table shows vaccination coverage and timeliness by age at the time of the survey, and also by whether the child was born before COVID or after COVID, so what we're calling the COVID era. So for the purposes of this analysis, we defined the COVID era as beginning on March 15th, 2020, when the first set of COVID restriction measures were announced nationally. Because of the truncation of the time during which the survey was conducted and the introduction of COVID, the upper bound of children in the COVID era is 15 months. So we see that coverage with the third dose of PCV was about 90% among children born in the COVID era, and that's shown in the first 2 rows with just different age groups included. In the second row, we have children aged 13 to 15 months, and we included the same age group for children born pre-COVID for comparison. And we see that coverage is comparable, perhaps even a little bit higher in the COVID era. And just to check that we didn't have any bias in that 13 to 15 month age group in the pre-COVID era, we did it among children aged 13 to 59 months. And we see that coverage is comparable. So in summary, we see that the moderately high levels of coverage with the third dose of PCV in the pre-COVID era was sustained in the COVID era, and perhaps coverage was even a little bit higher. But the caveat is we're doing this within the Kilifi Health and Demographic Surveillance System, which is a highly researched population and so may not necessarily be representative. Next slide, please. We are also able to leverage both our clinical and community surveillance to assess long-term trends in clinical pneumonia. A previous analysis published in 2019 by Mika Silaba and colleagues showed that the introduction of PCV10 in Kilifi was associated with a 27% reduction in the incidence rate of clinical pneumonia among children below the age of 5 years. And that's shown in this figure by that step decrease in the early part of 2011. So that analysis included 4 years post-introduction of PCV, and we've updated that analysis as shown to include 2016 through 2019. And this figure shows the actual and modeled clinical pneumonia rates over time. And we observe that the temporal trend in the post-PCV period, which is shown by the red slope in this figure, remains comparable to that in the pre-PCV period, indicating that the impact of PCV on clinical pneumonia has been sustained and having no evidence of serotype replacement. Next slide, please. We've also updated, sorry, one back. We've also updated an analysis on the long-term impact of PCV10 on invasive pneumococcal disease. There's an initial analysis done by Laura Hammett and colleagues that went through 2016 and showed that there were substantial decreases in invasive pneumococcal disease caused by vaccine serotypes, as well as decreases in the incidence rate of bacteremic pneumococcal pneumonia through to 5 years after introduction of PCV. And this is among children below the age of 5 years. So we extended out the analysis through to 2019 and found that the impact of PCV on vaccine serotype disease and bacteremic pneumococcal pneumonia was sustained, although the impact was not statistically significant for bacteremic pneumococcal pneumonia, and that's likely due to small sample size. We're really seeing very few cases of this. So these findings underscore sustained impact of PCV on invasive pneumococcal disease and bacteremic pneumococcal pneumonia, despite residual nasopharyngeal carriage of vaccine pneumococci. Next slide, please. So the findings I've shown are quite positive. We have a vaccine that is effective, which is consistent with findings in other sub-Saharan African settings, and there's high uptake, at least within our surveillance area. So what's next? There are obviously a lot of future priorities for PCV and control of pneumonia, but I'll pick on two that are of particular interest to me, and those overlap with some of the points that Lee had mentioned in his presentation. So first is sustainability of the PCV program in Kenya. Kenya has transitioned into a lower middle income economy, which is great, but that has triggered the Gavi transition process. And we know that PCVs are relatively expensive, which creates a challenge for the financial sustainability of Kenya's PCV program. There are various approaches to reducing the cost of the PCV program, but one that may have cross-cutting benefits is a reduced dose schedule, such as one primary dose and one booster dose, as used in the UK and in evaluation in other settings. And the context in Kenya seems ripe given high vaccination uptake and low incidence of vaccine serotype disease, despite residual carriage. But this would need a well-designed evaluation, comprising implementation and collaboration in the public health system, and really a large, well-functioning surveillance system to monitor for any increases in disease. The second priority I see is research into pneumonia in adults, and the COVID pandemic has highlighted the issue of pneumonia in adults. Outside of COVID, there's a need to measure the burden of pneumonia in adults. And although there are innovative diagnostics such as urinary pneumococcal antigen testing, there's a gap in validation and sustainability of testing within a programmatic setting such as ours. There's also a need to understand the risk groups for prioritization given different age structure and different frailty risks, and also a need to think about ways to effectively deploy interventions, including vaccination, in a setting that does not have a well-established platform for adult interventions. So there's still more work ahead. I'd like to acknowledge, next slide, please, all the people who've contributed in one way or another to the information I've shared with you today, from the community participants and patients, our partners at the Ministry of Health, at the Kilifi County Department of Health, the different teams within Cambry Wellcome Trust, including all current and past PCVIS team members, IVAC, who has been a technical partner over the years on epidemiology and communications for this work, and the funder.
Of Kenya. I'm going to turn it over to Dr. Klugman, who leads a pneumonia portfolio at the Gates Foundation, to kind of zoom back out to give us a perspective of where we're headed. And apparently, despite a pandemic, it's again, PCV progress has been remarkable, and then amazingly been able to continue despite the pandemic. So I'm over to you, Dr. Klugman.
So thank you so much, Victoria, and thanks to the other three speakers. Really been fascinating presentations. And so I've been asked to say something about the impact of this awful pandemic on pneumonia, and whether there's anything kind of positive that's come out of it going forward. And so I'm really just going to address what's on this slide. And it's a little broader than just pneumococcal disease, but let's start off with diagnostics. At the beginning of this pandemic, there were not more than perhaps half a dozen academic centers in all of Africa that could do a diagnostic PCR test. And in fact, one of the first contributions of the Gates Foundation to the pandemic very early on, in very early 2020, was a grant to the Africa CDC to try and increase PCR capacity. And today, virtually every country, at least with regard to COVID, is able to use PCR as a diagnostic. Now, it's not in fact used for pneumococcal disease specifically, but it's certainly a step forward in diagnostics we didn't have before. Pulse oximetry, the ability to detect low oxygen as a risk for COVID, is also a huge risk for children with pneumonia. And over the years traveling through Africa, I've seen the total lack of availability of these oximeters. Sometimes clinicians hang on to them themselves because if they put them down, they get lost. And they're relatively cheap and inexpensive, and could be very valuable. So it's another area where perhaps there's been some better availability. In terms of surveillance, there is a big influenza surveillance program called GISRIS, and we funded the expansion of that to COVID. One of the particular things that I want to address is mortality surveillance. That's a big problem. We really have virtually no idea what the impact of COVID has been in most of Africa, especially because the mortality is concentrated in adults, and was mentioned earlier, adult surveillance has really been very, very poor. And so, the DHS data on mortality are very interesting. Obviously, Kilifi would be an opportunity, but as we've seen, Kilifi is hardly representative of the rest of Africa, actually showing an increase in coverage of PCV during the pandemic. So we're really interested in knowing what's been going on with mortality, and are trying to help fund some of that. Another real game changer has been the ability to do whole genome sequencing. And here, in fact, the pneumococcal world is interested, because surveillance for new serotypes is virtually entirely sequence-based now. And there are centers throughout Africa that have been set up for whole genome sequencing. And that's another big step forward. Not specific to pneumococcus, but obviously we have a number of vaccines, including RSV vaccines, that should be coming soon for pregnant women, and also a Group B strep vaccine. And so pregnancy pharmacovigilance is an extraordinarily important thing. And this is also being rolled out now. And in fact, the de-risking of maternal immunization by the immunization of literally millions of pregnant women for SARS-CoV-2 has also made a significant contribution, we hope, to speeding up maternal immunization going forward. In general, a shout out to the folk, the first talk, delivery is hard. In fact, in science, this week, there is a call for the National Institutes of Health to set up an implementation research division, because as we've all heard, it's all very well having vaccines, but if people don't take them, you don't get very far. And And so, the other side of the presentation by Lee, great that vaccines are now available in most Gavi eligible countries, PCV, but only 51% of all kids are getting it. So that's a huge area going forward, and maybe some lessons will be learned from the pandemic. I think that in the interest of time, I'm going to leave it there. I do have a very important message to announce related to PCV, but we'll come back to that at the end because I'd like us to have some time for questions. So I'll stop there.
Thank you so much. Thanks, Professor Klugman. Thank you to each one of the speakers. I know we had asked folks to put their comments in the chat, and so we did have a question very early on. Leith had asked, related to India's remarkable progress to move from the NITAG recommendation to introduction of PCV at the national level, scale up at that kind of scope in terms of how does that compare with other nations? And so I know 7 years seems like a long time. Amazingly, 7 years with the latter part of that during a global pandemic is remarkable. So I was just going to turn it over to Dr. Hampton first, and then Dr. Roy, his thoughts afterwards. But your how does that fare in terms of other countries, and how does that factor into our decision making?
Sure. So our experience at Gavi has been that there's a lot of variation from country to country. So a lot of things have to happen in between when a NITAG recommends a vaccine and when it goes into use, not least of which is appropriation of funding from the national government to put it into use. On average, it takes around 2 to 3 years in most cases. But I think India is very much a kind of special case in that, as you know, there are states in India that are larger than many of the other countries that are eligible for Gavi support, or they're introducing PCV. So at least from my perspective, the fact that the entire country is using PCV, which as noted is a relatively expensive vaccine at all, is an enormous accomplishment. And it's a testimony to the work by Dr. Roy and his team and everybody else in the Indian Union to make that possible.
And Dr. Roy, did you want to comment? I know again, you guys were making great progress, and then the pandemic hit, and you still were able to sustain that. Any thoughts, or sort of, again, it was a wonderful presentation about lessons learned and all the key elements that need to go into that. But is there anything that you might highlight? I love the slides at the end that showed this is the context of the real world work that's going on. But anything else you'd like to highlight about 7 years? I'm sure you've aged considerably, but learned a ton in those 7 years.
Yeah, just going back to what Dr. Hampton was mentioning, because India is a large country and we have a 27 million cohort. So yes, the supply issues, and as I said, we didn't have a local manufacturer of PCV. So that was one of the constraints. But having said that, I'll tell you, if you look at the studies that have come out recently, in these last few years, from 2000 to 2015, 19, the childhood pneumonia mortality has actually come down in India. And besides the vaccination, there are other initiatives the government has taken on nutrition. There's a portion beyond on safe cooking fuel, and on a lot of other measures that have gone around it. So yes, it took quite a long time for the pan-India expansion, but in the same period, a lot of other initiatives have been taken which address the other risk factors that contribute to the pneumonia mortality. That's.
Thank you. And in many ways, India is almost sort of a conglomeration of many small countries, given sort of the complexity and diversity at the subnational level. One of the questions one of our participants asked, which is timely as well, is that given the link between PCV introduction and the importance of surveillance and sort of knowledge sharing within those networks, any thoughts about how to advance or how to approach advocacy for PCV introduction in conflict or fragile settings where surveillance systems, as she described them, as not as robust, and I think some of them they're not even existent. So how do we build that case, and how do we start in environments where data are not available due to conflict or fragile settings with vulnerable populations? And I'll ask Dr. Hampton or Dr. Klugman to comment.
Right. So I think, in a sense, that was one of the ironically encouraging parts from the analysis of the study that I was summarizing, which is that one thing I also didn't mention is that for many of the countries that were participating in the surveillance networks, they didn't actually wind up generating much in the way of pneumococcal surveillance data. So I mentioned that Gavi, for example, had been funding the global invasive bacterial disease network. One of the things that we found, unfortunately, was that largely, I think, because of all the pre-treatment with antibiotics before samples were taken, many of the sites were not able to actually detect very much pneumococcal disease that everybody thought was there. So the bottom line is, the experience from these surveillance networks, we don't actually have to have country-specific data. It was more the engagement with the experts in individual countries and with the decision makers that those surveillance networks facilitated. That was actually probably the really key part. So I think in terms of getting them into conflict countries is that we've seen that decision makers are open to the data and that can be generalized across countries. I think there's always going to be a challenge with competing priorities. As Dr. Klugman noted, in those contexts, that's where the delivery is the really hard part. But I think that our experience so far has actually been encouraging that even if we don't have country-specific surveillance data, it's still very possible to get across to decision makers the importance of this vaccine.
Maybe I'll just make a comment or two to follow that. Lee, I found your study fascinating, that it's more important to do a study than to actually look at the results of it in terms of influencing politicians. Let me tell you that the road to the vaccine PCV in India would take an hour's discussion or more. But political will is critical. You heard that for all the delay, it took precisely 1 week for the Minister of Health after the licensure of the Indian-based product to announce the rollout. Now that followed a lot of previous work, but the previous administration, in fact, in India were so against any external funding for the development of that program. We had to switch the entire, because we funded that program ex-India. We switched the entire program to the Gambia 6 or 7 years ago. And eventually, in fact, that vaccine got an export license before it got India licensure. So Leith asked the question, yes, lots of stories, but in relation to this specific question, so we are now funding in Somaliland a demonstration study that you can do a mass campaign in refugee camps to impact pneumococcal disease. And I'm also really happy to see the extent to which Gavi is now talking about catch-up as part of the rollout. And it's really, we're very excited going forward by some of these opportunities. And it is time to get conjugate vaccine into the poorest of poor parts of the world, as well as those middle-income countries that you mentioned, Lee. That middle-income gap is still there. There are lots of countries too rich for Gavi and too poor for the major pharmaceutical costs.
Dr. Kogusha had a comment, and I think I know she's going to follow on to that. Go ahead.
Yeah, so I was actually going to add, when it comes to fragile settings, we're also collaborating with Epicenter, Paris and Niger on a fractional dose catch-up study, which is funded by EDCTP. So that perhaps might also be of interest. It hasn't started yet, but the timeline is expected to be about 18 months. So looking at the impact of fractional dose catch-up among children on carriage of pneumococcus.
And those studies are important to understand sort of how those fragile settings differ and what same lessons could be applied. Now my question was, another participant asked, in the context of how do you prepare policies or guidelines to deal with pneumonia and pandemic preparedness in the future, given the limited resources, and whether those resources be, as we kind of have mentioned, sort of political will, funding, research capacity sometimes, how everything is finite in terms of a lot of these settings, and is there a way or how do we keep, with the exception, in addition to things like this World Pneumonia Day, where we kind of pause for a minute, take stock of both the wins and challenges ahead, what would be some of the thoughts about how to guide countries to prepare guidelines or policies so that preparedness might be improved in the future?
Well, we have a fabulous opportunity right now, don't we? I mean, the whole world is brought to its knees by pneumonia pathogens. So if ever there's a chance to say pneumonia is important, guys, and then maybe pivot from the pandemic to the existing burden of pneumonia mortality and say how important it is to control that too. So I think the future is in our hands right now. We do have a unique opportunity, and political interest will wane as this pandemic fades, that is for certain. So yeah, I think we have an opportunity right now, but it is true broadly that pneumonia is hugely is neglected in terms of research funding and political attention.
And I'm going to go ahead, Dr. Roy. Thank you.
Thanks, Victoria. Just to a quick thing that tomorrow being the World Pneumonia Day, Government of India is also launching a special 3-month campaign. So it's an integrated pneumonia control. So right from early diagnosis, treatment, health seeking behavior, and PCV. So again, I think tomorrow the health minister is going to launch that campaign. So again, it's another effort to control pneumonia. So it'll be a 3-month campaign from November till end of February next year.
Wonderful. Thank you. I know it's hard because sometimes I know here at IVAC, we tend to focus on the V as really a key cornerstone of a pneumonia strategy, but that all the things that you mentioned and India's recognition of that is really key. I'm going to turn it over to Dr. Klugman for his sort of last thoughts. He had one comment and one announcement he was going to mention related to sort of things to get excited about as we mentioned, officially World Pneumonia Day. It will be tomorrow, and I know there are many more events looking at data, talking about key issues that remain. But I think it's also exciting that there is a ton of work going on despite, despite the context of the challenges of the pandemic. Over to you.
So let me just say that obviously to everybody on this call and everyone listening, you're all aware of the extraordinary role that pneumococcal conjugate vaccine has played in reducing pneumonia. We saw the beautiful data from Wangechi of how pneumonia has gone down in children. It's true that in fact, vaccinating kids also protects the elderly who also have a large burden because it stops transmission. The problem, if we do have a problem, is that there are 100 serotypes of pneumococci, and the most broad vaccine available at the moment only covers 13 of them. So the announcement is that, and it came out yesterday, that the Bill and Melinda Gates Foundation has contributed $90 million to Subhash Kapri, who is the person who was behind that PCV10 program in India, who's now working in Seattle and set up a company specifically to make vaccines for the developing world. And so after about $100 million investment in starting getting the factory up and running, we announced yesterday a up to $90 million grant to make a 25-valent conjugate pneumococcal vaccine specifically focused on pediatric serotypes around the world. So you guys may know that Merck have a 15, Pfizer have a 20. Both of those at the moment are focused on the adult serotypes in rich countries. And this new vaccine will be focused on the remaining burden. And there is still quite a large remaining burden. One of the ironies is that the diversity of serotypes in poor countries is greater than rich countries. So the remaining serotypes still play a big role. And we're very excited to make that announcement and hope that they're successful.
Thank you. Wow, that's quite impressive. Again, any of these advances these wins that are being announced in the context of what's going on is really exciting. I know there have been questions in the chat about adult pneumococcal vaccination, and we've sort of focused today on child. And again, the wonderful comments from Dr. Roy has mentioned has highlighted that we could probably have done a separate webinar on each one of these topics. I'm just going to conclude by thanking everyone, our remarkable speakers. We were really blessed and grateful for folks sharing their expertise. Over to Bill, if there's any last comments, and if not, thank you again for both sort of the participants and the panel speakers. We're really grateful for your time.
Yes, I too thank all the speakers and all of the audience for joining us. Very exciting developments, Keith. We're very excited to hear about the PCV 25 work, and that's really exciting going forward. So thank you to all of you, and please continue to celebrate World Pneumonia.